So I'm going to just start by introducing myself. So like I said, my name is Rosie Mahendran. I'm a pelvic floor physiotherapist. I practice out of Cornerstone Physiotherapy out of our 55 University Avenue location. And that is like right in the heart of downtown. But we do have two other locations, one at Carlton and the other one at Yonge, and pelvic floor physiotherapy is offered at both. We also have one in Burlington if some of you live out in the West End as well. All of our locations are accessible by the subway, so that's helpful. I started pelvic floor physiotherapy in 2015. I graduated from McGill University with my master's in physical therapy. And while I was there, I started doing courses in pelvic health offered in my master's program, which is a little different from everywhere else where you have to sort of do it after you graduate from physiotherapy. And so I love it. It is everything that I hoped to achieve in my career, and I'm grateful to be able to be here and teach you guys more about it. So our goal today is to be able to discuss what pelvic health is. We're going to learn a little bit about some conditions that I treat and how I treat them. And we're going to learn about some of the components of what a pelvic health physiotherapy assessment and treatment looks like. And again, we are going to have some time for questions and answers specific to what you guys might want to talk about. So what is pelvic health physiotherapy? So it is the assessment and treatment of conditions resulting from the dysfunctions of pelvic floor muscles. And these things can include incontinence, pelvic pain, or pelvic organ prolapse, which I will talk later about what those actually are. So the key difference between a pelvic health assessment and a regular physiotherapy assessment is that we are specially trained, as I had said in the beginning. So you have to go get special training after you finish physiotherapy school to be able to conduct a pelvic health assessment. So we're doing a comprehensive orthopedic exam. So we might be looking at your low back, your hips, your thorax, but then we're also doing an internal vaginal and rectal exam of your pelvic floor muscles. On top of that, we're also looking at outcome measures that measure your psychosocial evaluations, essentially. So more like your stress, your anxiety, your depression, your fears. We might be looking at your thoughts and beliefs around the pregnancy or your symptoms. And the reason we do this is that we really truly incorporate a biopsychosocial approach when we are looking at the individual, because everybody's different and there's all different types of triggers to pain and symptoms. So the internal examination is usually what people are like, oh my gosh, about. And the reason why we do that is because if you think about your knee or any other part of your body, if you had injured it, you would, or you're experiencing some type of discomfort, you would want someone to be able to look at that knee and see and assess what's going on. In order to do that, you might have to expose the knee and really have someone palpate or feel what might be happening. So the same thing goes for these internal muscles. We don't truly know what's happening unless we assess and look at them with an internal examination. So the pelvic floor muscle is the only group of muscles that have 5 roles. It says 1, 1, 1, 1, 1 because they're all important. Let's talk a little bit about anatomy for a second. So I have this paper model of the pelvic floor, so I hope it makes a little bit of sense. But what we have right here is the pubic bone. And then if we follow that along here, those 2 parts are the bones of the hip, right through there. And then if we go behind, we've got the 2 dimples in our back, that region back here. And then this would be where our low back connects to our sacrum and then our tailbone. So it would look something sort of like this, your pelvis. And we've got 3 layers of pelvic floor muscle. So our first layer is the vulva. So where the labia is, that's all made of musculature, and that would be our layer 1. Our layer 2 would be the perineum, which typically is affected when people have sort of tearing or episiotomies. It's what needs to relax in order to be able to facilitate birth. And some urethral muscles are part of that layer 2. Then layer 3 are all these lovely muscles here. So this is the vaginal opening, and this is the rectal opening. And as you can see, all of those muscles are able to be assessed. Some of those muscles, the reason we do that rectal exam is some of those we can't really access unless we're in rectally. And then some of them we can get through vaginally. These guys are important if we're having like deep hip pain or something like that, then we might want to look at rectally what's going on. So 5 roles, let's talk a little bit about that. The first one is support. So the pelvic floor muscles, you can't really tell here because it's paper, but they're like a bowl-shaped muscle. And what they're going to do is they're going to support your bladder, your rectum, and your uterus. So things like in pelvic organ prolapse, you might have a descent of those organs. So those pelvic floor muscles should be able to contract in order to support those muscles. Sphincteric, so these muscles will wrap around the opening of the vagina and the urethra and the rectum and allow for it to open and close. So if you are having to go to the bathroom, you should be able to sit on the toilet, relax those muscles, the muscles will open, you'll be able to have a bowel movement or void. But then when you're going on throughout daily life, they should be able to stay closed so you're not leaking or having any symptoms. Number 3 or 1 is sexual. So what these muscles will do is that they have to be able to relax in order to accommodate for any sort of object if you want to be having intercourse, whether that is a penis or any sort of dildo or anything like that. Those muscles have to be able to relax. And now to achieve an orgasm or something, they need to be able to contract and relax. So that becomes really important. And it's also important in men because they're the muscles that help achieve an erection and it also helps support orgasm. Everybody has a pelvic floor, not just women. My presentation is specific to cisgendered women, but keep in mind that everyone also has a pelvic floor and might experience these symptoms too, regardless of if they've had a baby or not. Stability. So everyone thinks when we talk about core, we're talking about our 6-pack muscles. But truly when we're talking about the core, we are talking about our pelvic floor, a muscle called the transverse abdominis, which is a deep layer of muscles behind our 6-pack, our diaphragm, and a group of muscles called the multifidus. And again, I will go into detail about that. And those guys are anticipatory muscles. So what that means is that they sort of anticipate movement before it happens and they turn on to help us move throughout life, essentially. And then finally, sump pump. So these muscles help to contract to be able to take out fluid out of our system. So if we've had any sort of trauma or after birth, what can happen is we get pooling and swelling down in the vaginal region. And what we can do is we can contract these muscles and that will circulate back through our system. It's the same as if we were having an ankle injury. So if we rolled our ankle and we had swelling, we can pump our foot up and down and our calf muscle will be able to take that swelling out. These muscles do the same thing. So 5 really important factors of the pelvic floor. So when I do an internal palpation, I'm looking for 2 things in the most simplistic form. I'm looking to see if the muscles are hypotonic or so are they weak? Can they contract well and are they lengthened? Or are they hypertonic? Are they tight and short and not contracting as well as they should? So some conditions you might see with a hypotonic pelvic floor, so a weak pelvic floor, is prolapse or urinary stress incontinence or fecal or gas incontinence or potentially some low back pain. And then some of the things you might see with a hypertonic pelvic floor, so a tight pelvic floor, is something like pelvic pain or dyspareunia, which is painful sex, or vaginismus, which is the muscles actually are spasming and unable to have anything penetrate. Interstitial cystitis or painful bladder syndrome, any type of pelvic girdle pain, constipation, or hesitancy and retention. And what hesitancy is when you go to the bathroom and you are sort of stop and start with your voids, and retention is that you're not voiding everything out completely. So some stats. So 1 in 3 women will experience urinary incontinence. 1 in 3 women who perform Kegel exercises do so incorrectly. 30 to 50% of women who have given birth have a minor pelvic organ prolapse. 1 in 4 women suffer from dyspareunia, so painful sex. 1 in 7 women will have pelvic pain, and half our population ends their lives in diapers, and incontinence is the #1 reason for that, and the reason why people end up in old age homes. So all this to say, all of these things are treated by pelvic health physiotherapy, and they have great success with it. So these stats shouldn't really be stats, because that 1 in 3 women could get better. So the pelvic floor is super important, as you can see. And in Canada, we're behind the times. So what's really awesome in other countries like France is that they actually pay for 6 postnatal physiotherapy visits after you give birth to prevent and treat any pelvic floor dysfunction. So you cannot even have symptoms, and they will make you go to pelvic floor physio. They'll pay for it so that you can prevent any future symptoms. And in Great Britain, if you have a pelvic organ prolapse, or if you have any type of incontinence, they make you go to pelvic floor physiotherapy before you become a surgical candidate, because so many people do just fine with the conservative care. And I think it's about 6 months that you have to undergo before they even consider you a surgical candidate. So all that to say that conservative care is primary care, and it's 90% of people will get better with just that type of care alone. So more than just Kegel. So whenever you tell someone, at least in my experience, pelvic floor, they automatically assume a Kegel. So a Kegel was introduced in the 1940s when Dr. Arnold Kegel did a digit insertion into the vaginal wall, and was found that the muscles actually can contract and relax. So he assessed the quality of it and determined that it was really important to be able to do that internal assessment to assess the quality of that, that contraction and relaxation. But then somewhere along the line, this sort of shifted to verbal instructions by medical practitioners. And then in 2009, it was decided that a vaginal examination was really what was appropriate to confirm that proper Kegel performance. And then the lack of internal evaluation made for a less effective pelvic floor exercise and could actually make symptoms worse. So I want to touch on that a little bit, because what happens when a woman, or when anybody does a pelvic floor, is that if you don't really know what's going on, commonly what we'll see is people will contract their inner thighs, they'll draw in their belly, they'll squeeze their glutes, they might hold their breath to do a Kegel. So if I did that, it kind of looks like this, and it's not very effective, because those muscles aren't supposed to work consciously. They're kind of unconscious. So really, I shouldn't actually see anything happening on the external when I see a Kegel. You should be able to squeeze and lift when you do that Kegel, and a lot of people might just squeeze or will lift without the squeeze, which again, appropriate to be assessed internally. The other thing that can happen is a lot of people will just do these Kegels because they think, that's what I have to do, and they might just not need it. They might be perfectly strong, and they actually have the opposite problem, that they're tight. And really, we don't know, and we're just giving these people Kegels, and it might just be making their symptoms worse. So I want to touch a little bit about that core I was talking about. So we've talked about the pelvic floor. I'm just going to touch on the other 3 muscles of that core, which is the diaphragm, the transverse abdominis, and the multifidus. These guys work together synergistically, so as a unit, to help you sort of move throughout life, essentially, and they function together. So if one's not functioning well, then most likely the others aren't working as well either. So all of these things are related to your posture and alignment. And so a lot of people will say, well, I have to sit up straight and I have to tuck my pelvis in. And there's all these sort of rumors about what good posture is. But posture depends on the person's body and the body that's in front of you. So the posture that might work for one person might not work for the other person. And so again, we want to, as your body's changing and you're developing a baby inside of you, you might start to shift in alignment. And that actually might be normal, might be the best way for you to facilitate a contraction. So going against that might actually do more harm than good. So it's always good to get that assessed and not assume the right posture for you. And so all of these are tied in to each other, because posture will affect the way your breathing is, it'll affect the way your pelvis sits, and maybe affect the way you contract and relax those muscles. So let's talk about the diaphragm for a second. The diaphragm is your breathing muscle, and so what happens as you breathe, the diaphragm will descend and contract and allow for more air through the lungs. And then when you exhale, the diaphragm will come back up. Now, in a well-functioning core, your diaphragm will come down and your pelvic floor will come down with it. And then when your diaphragm comes up, your pelvic floor will follow suit. And so if that's not happening and working well, then you're going to get some types of symptoms. So maybe if you cough and your pelvic floor is driving down further instead of coming back up, you might find you leak. And so we want to get this lovely interaction between your diaphragm and your pelvic floor. I'm going to share my screen for a second, and I'm going to show you guys how that should work. And I think it's done on an ultrasound. So give me 1 second. Awesome. All right, so this is what should be happening. So typically a lot of us are chest breathers, and what we'll be doing is you'll see here the pelvic floor is moving, but it's not moving well. And when you look at this, you think it's moving fine, but then you're going to see as it transitions that when you do a belly breath, the descent of that pelvic floor is a lot better. And you can see a lot more movement happening. And this becomes super important for pushing and delivery of a baby as well. So as you saw there, so a lot of us are chest breathers. And what's going to happen is when we do a chest breath, we're not going to get deep pelvic floor movement. So when we switch that to a belly breath, we're going to find our pelvic floor moves a lot better, and we're able to make a better connection to that pelvic floor region. That's not to say that everyone needs to walk around breathing into their belly, but it might be something important to do to try to access different parts of your body. So let's move on to the transverse abdominis, which is an important core muscle. So it runs around your body like a corset. So it attaches into your belly, comes around to your low back, and it helps stabilize the low back and the pelvis. It's really key for helping pushing your baby up. So the transverse abdominis, what's going to happen is as you inhale, remember that pelvic floor is dropping down and your transverse abdominis is relaxing. And so when you exhale, you're going to draw up that pelvic floor and your transverse abdominis is going to contract. And that's how it works in unison together. So there's that co-contractions that's happening between all these muscles. And so we can use that transverse abdominis to train the pelvic floor. We can teach you to contract your belly to get that pelvic floor contraction, or vice versa, teach you to create that pelvic floor contraction to get your belly. So women who've had C-section, they might have more problems in the abdominal part of it as opposed to the pelvic floor part of it. And so we can use that little hack to help people. It's also thought that sometimes this muscle helps improve diastasis recti, which is the separation of your abdominal muscles, and kind of help bring them together. We're going to touch a little bit more about that later on in the presentation. And finally, the multifidi. So those muscles will run along your spine, and they are just help stabilize your spine, and they function with the core as well. And it's thought that if they're not functioning well, you might lead to some low back pain and chronic dull low back pain. So pregnancy and your pelvic floor. So as you see here, the core is probably one of the most important parts of your body when going through pregnancy and postpartum as well, but yet little attention is given to it. So like I had said earlier, you're probably only been told do your Kegels as related to pregnancy and even postpartum, but really now we should know that internal assessments need to be done before you can determine if you even need to do Kegels, because again, you could be tight. Internal assessment should be done to make sure you're contracting the right muscles, because we can easily fake it by using your inner thighs or other types of muscles. And then not a one-size-fits-all dosage. So let's talk a little bit about that. So oftentimes if you get that sheet of paper, it's going to say do 300 a day or whatever amount of Kegels. And what can happen is when I do an internal assessment, I will feel that the person, so I'll go in and here, I'll show you guys from here. So I will go in and I'll say, okay, I'm going to ask you to do a Kegel, whatever way you think that is for you. And the person will do the Kegel and they actually have a great squeeze and a great lift. And they'll be like, okay, let's hold that for 10 seconds. And so as I start counting, maybe around that 5-second mark, they start to flutter away. So this is no longer an issue of strength, but this is an issue of endurance. So doing 300 a day is not going to improve your endurance. Doing 10 holding for seconds is going to improve your endurance. So that's why it becomes important to figure out what is the reasons and what is going on in your pelvic floor. Is it a strength, an endurance, a timing issue? And treat accordingly. The other thing is, remember we talked about how a tight pelvic floor might also produce symptoms. So if you have a tight pelvic floor and you feel like you can't contract that muscle or you don't know how to contract that muscle, a lot of people will say, oh, well, I'm just weak. I don't know how to use that muscle. But really what's happening is that these people might be tight. So if I look at my bicep here, and if I'm tight through the bicep, I might be stuck here. And we know my elbow can really do this. It can extend all the way. So if I'm stuck here and you ask me to lift a bag, this is how much force I'm going to be able to create from here to here. But then if you ask me to relax and then pick up your bag, look how much force I can generate, a lot more. And so the Kegel will work the same way. If you're stuck here and then I ask you to contract, you're not going to be able to get a good contraction. But if we get you to lengthen that muscle, then all of a sudden we've got way better contraction happening. So what can you do? So I realize that a lot of people might have already given birth. So I'm just going to talk a little bit about being prenatal, and then we're going to go on to the postnatal after. But if you are prenatal, it's shown that women who did pelvic floor muscle training between 20 and 36 weeks of pregnancy had a lower rate of second stage labor than women who had no training. They had less pregnancy-related low back pain and pelvic pain than those who did no training, and they were less likely to have urinary incontinence at 36 weeks of pregnancy and 3 months postpartum. So what we would do prenatally is we would help you we would educate you on the best way your body should be able to relax in order to deliver that baby. We would be using breathing strategies. We might be doing things like perineal stretching to help kind of relax the muscles as best as possible. We might measure your Kegel strength and endurance and teach you kind of how to do those. So postpartum, you're ready to do that. We might give you education on exercises that might be helpful for helping improve hip opening or helping you improve the position you want to be in when you deliver. We're going to go through the positions of birthing with you, and we're going to actually check internally, okay, is this actually the right position? So sometimes in clinic, I'll have women, again, this is all up to everyone's comfort level, but some women want to be on their hands and knees during pregnancy. So we'll actually get in that position and I'll do the internal. I'll say, okay, can you push as if you were going to push to deliver? And they might contract instead of relaxing. So we might train them how to do that better, or we might say, hey, this might not be the best position for you. Let's look at something that might be better. So those are some things we'll do. And the most that we're going to do is we're going to facilitate as best as we can to prepare what your body is naturally already able to do. So I wrote let me just share my screen again. I'm scared that it's gonna not work, but I wrote a blog on how to prepare for childbirth before labor, during labor, and postnatal. So you guys I'll share that with Mommy Monitor, and then maybe you guys can take a look at that later. But just to show you guys. So that is the blog. It's on our website. And what we do here is we just go through sort of the physical things that might be important to look at before labor, sort of who should be part of your team, what pelvic floor physiotherapy is, what might be in your birthing plan, what kind of exercises are important to do and how you should exercise, and then some things that might be important during labor, and then postpartum. So you guys can take a quick look at that as well. Postpartum. So oftentimes people are going to come postpartum, and if they're going to see a pelvic floor physiotherapist, they're going to experience symptoms such as incontinence, pelvic organ prolapse, any type of scarring or issues related to scars, low back, hip pain, SI joint pain, diastasis recti, pelvic pain, or they're just looking to return safely back into their activities. So I want to discuss sort of what these are, what the symptoms are, and what to look for individuals who are postpartum. So stress incontinence. So stress incontinence, what that is there's a loss of urine due to increase in an intra-abdominal pressure. So if you cough or you sneeze or you laugh or you do any sort of transitional movements, you're going to find that you might leak. And that's due to the intra-abdominal pressure that's occurring when you cough and your pelvic floor potentially not being able to efficiently mitigate that essentially. Urge incontinence, however, is urine loss associated with the strong, uncontrollable need to void. So what's going to happen is I'm going to get this strong urge that I need to go to the bathroom, and I cannot delay it. And so I'll run and try to get to the bathroom, and then I might find that I leak, which is different from if I just cough and I leak. And this is often associated with urgency, so that strong sensation to void, and frequency, so having to go more than 8 times in a 24-hour period. So in the literature, it says that 5 to 8 times is considered normal. Again, keeping in mind what people are drinking. But oftentimes, women will actually have these symptoms even before having a baby or after having a baby, and they won't ever address it. And that might be a symptom that we want to keep in mind if you've had that before, because that might predispose you to potentially having urge incontinence, and maybe something you want to treat earlier on so you avoid that later on. Mixed incontinence. So urine loss, so pretty much mixed incontinence is urge and stress incontinence happening at the same time, which is typical postpartum. And important to know, pelvic health is the first line of defense for both these types of incontinence postpartum. And there's level 1 grade A evidence. So what that essentially means is a fancy term that they looked at all the research throughout the board, and that is just top quality, high-notch research that's out there about pelvic health physio. So pelvic organ prolapse. Now, this is going to sound a lot scarier than it is. I'm really trying not to fearmonger, because it is so treatable, and it really doesn't, it shouldn't affect people's quality of life, but it's something we should look out for. So what it is it's the descent of a pelvic organ into the vaginal space. So whether that's your bladder, your rectum, or your uterus. And what people will typically say is that it feels like an annoying protrusion near the vagina, or it feels like heaviness or pressure when they're doing certain activities. Maybe it's a high intensity activity, or maybe it's walking. It depends on the person, and it depends on the grade of the prolapse. And so some risk factors for this can be pregnancy, postpartum, straining, so just straining long pushing stages during delivery, or sort of that closed mouth type of pushing when delivering, or constant constipation might also cause that, because again, you're pushing really hard and creating that increased abdominal pressure. So what's going to happen is there's ligaments that hold everything nice and in place. So we're going to have these ligaments that hold the bladder in place, and then as we're putting a lot more pressure, they're going to sort of lengthen, and as they lengthen, the bladder is going to sit here, and it's going to kind of descend. It's not What's going to happen is going to hit the wall of the vagina first. And so when it hits the wall of the vagina, I'm just going to show you with my sweater, if I can get it. So when it hits the wall of the vagina, what you're going to see is sort of like that happening. I don't know if you guys can see that, but that. And so if you were to cough or sneeze or increase intra-abdominal pressure, if someone's looking, they will see sort of this descent. So it moves up and down. It doesn't stay like that. It does move up and it comes back down. So the thing about this is that if you have it, you can't make it go away, because those ligaments have stretched, and that's it. But it should not affect your quality of life, in the sense that a lot of people have it and they can do everything that they were able to do, and it's not really, getting in the way. They're not symptomatic. It's not getting worse. And so with pelvic health physio, what we're doing is we're teaching you how to do those Kegels and be strong through your pelvic floor, so that it never gets to a grade 4, which potentially might be a surgical, you might be a surgical candidate at that point. But yeah, so we're trying to do a lot of strengthening there, and make sure that you are effectively kind of controlling your pressures. Scars. So scars are often associated with childbirth, because you might have tearing, you might have an episiotomy, although that's not commonly done anymore, and C-section scars. So what we would be doing is we would be using mobility work to help stretch that scar or help mobilize it the best we can so that they're not a source of pain and that things are moving well. Oftentimes what happens is when women have a scar, and mostly I see this in my C-section clients, is that they'll kind of ignore that area. It's like, okay, it happened, forget about it. But when we do that, that representation in our brain of that area starts to shrink. And if that shrinks, then that connection and motor patterning is not as good as it once was. And so we might not be able to contract our abdominals as well as we once were prior to the scar. However, if we're mobilizing it and we're getting it moving, we start to find that things move the exact same way as before the scar happened. So just to give you a quick look, because I don't think everyone really truly knows what happens in a C-section. So again, I'm going to turn my screen share on, and this is our last time. And you guys are going to see sort of all the layers that we have to go through in order to have a C-section. So okay.
So skin.
So they go through skin, fat, fascia, abdominal muscles, peritoneum.
Peritoneum? I don't know how to say that.
Peritoneum.
Uterus and the bladder, you move out of the way.
So you move the bladder out of the way and you get into the uterus, then the amniotic sac, and then the baby.
All of them the way that you would. So
again, if nobody saw that, just kind of went through the layers, which is like 8 or 9 layers that they go through. So it's not just that skin or that muscle. We want to mobilize all of that region so that, you know, you're moving better and feeling better. So low back pain, hip pain, and SI joint pain. So this whole group of pain essentially is classified as pelvic girdle pain. And this is really common in people during and after pregnancy. And there's a huge link between pelvic floor dysfunction and this type of pain. So what can happen is a lot of people attribute it to hormones, and there's just no evidence for that. Like relaxin is just a normal thing that's happening in our body, helping us be able to make space for that baby. And it's not the cause of pain. What the cause is thought to be, there's actually many drivers. So just the changes in our body, so the stress, potentially the stress of having a baby, having to work, having to move more with a body that you're not used to, all of those things can drive up tension in our pelvic floor and the external muscles of our pelvic and sort of create like an asymmetry in our pelvis. And so what we do in pelvic health is we figure out where those asymmetries are and we try to sort of restore that, but we're never blaming that. We're not trying to blame your anatomy or your natural hormones on that, because those are really there to help us and improve our body's natural ability to make a baby essentially. So we're trying to work on relaxing the muscles. And what's most important about this is we're trying to help make it easier for people to function and improve their quality of life, because we do not want hip pain or low back pain to be a source of suffering for people. We want pregnancy to be as positive of an experience as it can be, and sometimes it's not because of these things. So we really want to be able to jump in and help make that better for you as best as we can. And finally, the diastasis recti. So I included this only because in the media it is heavily talked about, and there's just not a lot of accurate information. So I really wanted to make sure everyone felt comfortable and knows a little bit more about this from the scientific community. First and foremost, there's not a lot of research out there about this, but what we are finding now, so diastasis recti is the separation of your abdominal muscles. Your six-pack abdominal muscles. So what happens is that's a natural phenomenon that's going to happen to every woman, because the body needs to be able to expand to fit the growing baby. So your body naturally has to separate a little bit so that it can fit whatever's happening. And what's going to happen is after you deliver, everything should sort of go back to normal. But sometimes what can happen is some women might have a space between the abdominal muscles. And so traditionally what people were doing is they were putting 2 fingers in and they were asking people to contract, and they were seeing how big that separation was, and how big the separation was correlated to a dysfunction. We now know that's not the case because look at my 2 fingers and then potentially maybe someone a little bit bigger or smaller. That's not going to correlate. It might be that your abdominal closes completely and it's only 1 finger for me, but then for someone else, it might be like half a finger. So it's not a great way to measure. And the other thing we find is that it's not necessarily the space, but really, are you able to contract? Are those muscles able to contract as well as they once were? So what we're looking for is when we put our fingers there, we're actually looking to see if you lift your head up or do any sort of abdominal contraction, are you able to create force and tension? And then if you're not, we have to train how to do that. And so doming, tenting, bulging of your abdomen might be that your body is not responding to the pressures of its system, but it's not that you're making it worse. And planking and doing certain things are not going to make it worse. But what you want to look out for is sort of, hey, am I still creating tension or am I creating too much tension? And that might be where you want to consult a physiotherapist. A lot of people are asymptomatic and just are really worried about that space because we've talked about it so much. And so what we recommend is we want to and so then they stop doing exercises, right? Because they're so scared of making it worse. And then they weaken their body, which actually makes the separation worse. Because we know in the literature, in order to make a tissue stronger, we have to load it. So what's going to happen is people are going to come back and they're going to be terrified and not moving. We're going to try to get them moving as best as we can. However, that might not close that abdominal wall. And then that becomes talk about, is it the aesthetic or is it the function of it? Because if we're finding that it's functioning great, it's just changed in aesthetic, then that's a conversation we need to have. And potentially if that's something you want to explore surgery, we're going to support whatever your decision is, but we want to make sure that you're the most prepared for whatever you decide to do. So pelvic pain. So this is like a topic that's very near and dear to my heart. It's one of my favorite things to treat, but we talked about how a tight pelvic floor might lead to some pain issues. So things like dyspareunia, vaginismus, vulvodynia. So dyspareunia is painful sex. Vaginismus is the inability for the muscles to relax, so they're in constant spasm. Vulvodynia is pain in the vulvar region, so that first layer, and vestibulodynia is just pain at that opening. So what's going to happen, and a lot of people will experience vestibulodynia if they've had a scar, because that area where that scar or that tearing was becomes a little bit hypersensitive. And so many of these conditions are just treated through a lot of education, a lot of soft tissue work, and helping mobilize that area, helping you learn to facilitate that area, able to relax it, because naturally you're going to want to protect it when you're in pain. And returning to exercise. So after 6 weeks, typically 6 weeks is that healing time that you need for your tissues to heal, and then you can return back to any sort of activities you're doing. However, you don't want to go back. Let's say you'd love to do high impact activities. You don't want to go from 6 weeks of healing to right back to your high impact activity. You want to train like you would train for a marathon. And so it's important sometimes to see a pelvic floor physiotherapist, because we can check the pelvic floor, we can check your abdominals, we can check all the facets of that core, make sure everything's working well, and then see how you progress. So if you're leaking, then we might say, okay, let's pause and let's look at how your control is with a squat or a jump squat or something like that. And if you can't control that system, then we might bring that back down a little bit and then progress you accordingly. And that's not to say, some people just can't get to a pelvic health therapist. And I'm not saying don't do exercise until you see a pelvic health or therapist or an athletic coach or anything, because we know there's just so many benefits of exercise. What I'm trying to say is that if you are going to do exercise, just listen to your body and make sure you're avoiding those 3 P's, which are P, pain, and pressure. If you feel any of those things, if things feel off, then just kind of bring the exercise down to a level where you're asymptomatic and progress accordingly. So some take-home points. So if you have not given birth yet, or you're thinking about having a baby, you might want to think about just preparing for birth. So seeing a pelvic floor therapist before and sort of getting your body ready for what it might be going through. However, if you are postnatal and you've had the baby already, it's fine because you've done it and your body has healed, and we just want to make sure that we go back to using the core as functionally as possible. So if you're postnatal, and it doesn't matter if you're 3 years postnatal, if you're 10 years postnatal, 50 years postnatal, you can still come in and see a pelvic health therapist, and you can optimize your strength. I've had women who were 60 who've come in and improved their strength and had no more leakage or pain or whatever their symptom was, just because they learned how to contract that muscle effectively and relax it effectively. If you are within that 6 weeks, take the time and honor your body and let it heal. It wants, I think it's like if the cortisol levels are high in your body doesn't do well with healing. So you just want to give yourself that opportunity as best you can, because I know you have a newborn baby at home, and so it's hard. So try not to be doing any high intensity activities when you're in that 6 weeks. And if you have, that's okay. You know, some people do that, and we can't be hard on ourselves for, you know, having to lift the baby up in the carrier or something like that. Our bodies are made to do that stuff. Make sure that you try to get checked by a pelvic health physio, ideally before and after labor, but definitely after labor if you're going to return to high impact activity. If you, again, like I said, it can be at any point, 10, 50, 2 years, as long as it's after that 6 week period. Just a quick note on that. When you are going to see your midwife or your OB/GYN, I believe that they check at 6 weeks just to make sure like things are healing well. But what they're looking for is they're looking at the tissue integrity, but they're not assessing the effectiveness of the contraction and its ability to function throughout your life and your lifestyle. So that's the difference. So even if someone clears you and says, hey, your stitches are healing well, that might not necessarily mean that you're ready to return to whatever activity you need to do. And then finally, incontinence, prolapse, and pelvic pain are common conditions. So a lot of people have them and they're associated with pregnancy and birth, but they're not normal. And they can be treated and they can get better. And that is it for me. So any questions? I'm going to head over to my chat and see. All right. Don't think there's any questions yet. Oh, I got one. Any daily exercises to do at 38 weeks? So you are not limited to exercises at 38 weeks. You can do almost anything as long as it's not high impact or contact like hockey or any sort of sport like soccer. Nothing obviously in like heat, so hot yoga, nothing. And high altitudes, nothing like that. What I personally recommend at 38 weeks is that you're doing a lot of hip opening stretches. So any type of yoga, any type of stretch, dynamic or static. So static stretch is just holding a stretch in a position. Dynamic is moving through that. As long as you're doing that, that really helps open up and relax the hip muscles to be able to prep for birth. Perineal stretching is another thing that I highly, highly recommend. I can show you guys how to do it if you'd like, although I do recommend trying to get a professional to help you with that too, like in person. And the other thing I do recommend at 38 weeks is to do some core and strengthening exercises as well. It's shown that your testosterone levels are actually the highest during your 3rd trimester, so you can actually pick up weights and do weight training if you feel comfortable, because that's the stronger you are, the better you are going to be able to help push and have that endurance to deliver your baby. So at 38 weeks, that's what I would recommend, hip opening and general strengthening abdominal exercises. Might be a silly question, but would you be able to demonstrate a belly breath? Please show the difference between a chest breath and a belly breath. Absolutely. Okay, this is not silly because I don't think maybe like 2 or 3 people I've ever treated in my life truly knew how to do a belly breath. If you're a yoga person, you will probably know. So a chest breath, sorry about that. So a chest breath is this. So what's going to happen is you're going to see my chest come up and my belly might draw in. Some people actually draw their bellies in, but you're just not going to see much movement here. So if everyone could just put their hands on their belly, put your dominant hand on your belly, put your non-dominant hand on your chest. Now imagine that you've got a balloon in your belly and that balloon wants to expand 360. And that chest wants to follow along or stay where it is, but it never wants to go past that belly. So what it looks like is, so do you see how my hand moves away and moves in? It's really hard to see. It's almost better if I was in person with you guys, and so then as that belly's coming out, your pelvic floor should lengthen. And what I would do in my session is I would be internal checking to see, are you lengthening that pelvic floor, and trying to make that connection of what that feels like for you. I always just say do the diaphragmatic breath anyway if you don't feel it, because it's happening naturally. And then if you can make that conscious connection, great, even better. I hope that helped, and there are lots of videos online for diaphragmatic breathing as well. I would suggest doing it lying down, because then you don't have the weight of gravity. I find that when you're sitting, you want to do this, and then when you lie down, you're kind of relaxed and you can use that. If you try to do it and you're in a stressful environment, so if you've got like kids running around or, a lot of talking and noise, it's going to be really hard to concentrate. So even if you just threw on some sort of like soothing music and did it, you'll find it's a lot easier to coordinate that breathing. Also, if you have a baby or newborn, watch your newborn breathe and they will be doing it. You'll see their belly rise and drop and they won't be breathing through their chest. Can weight be part of incontinence? Yes, it can be. So, it depends, right? Like if you had the baby, potentially and you're a little bit overweight, sometimes you can just strengthen your pelvic floor and that's fine and you have no other issues. But sometimes, yes, like your pelvic floor might be strong and it's the weight and the pressure that might cause that. Truly, it's only because the abdominal wall doesn't know how to contract as well that might be leading to the problem, as opposed to the true weight issue. I hope that helped a little bit. Is there a point during pregnancy that you should avoid working your core? Are isometric contractions okay during all pregnancy? Also, lateral hip pain during sleep. Any suggestions on pain management? Okay, I'm gonna try to answer all of this. The only time I would tell you to avoid working on your core is if you have a tight pelvic floor or you're overactive in your pelvic floor, which you would want to get that assessed to know that. Also at the 38-week mark or 39-week mark, you might not need to if you've already been sort of doing that, or you've never been doing that. At 2 weeks, it's probably not going to be effective, so you probably don't have to. Are isometric contractions okay during all pregnancy? Absolutely. Again, as long as you are not a tight person. So with that lateral hip pain, I might think, listening to your story, you might actually be overactive through those muscles. So if you are, I might suggest for you, you know what? You don't need to be doing contractions. You actually need to be able to relax those muscles. I might teach you how to do it so that postpartum you know how to do it, but we wouldn't be focusing on that. With the lateral hip pain during sleep, a lot of times having a pillow in between your knees helps so that it's not crossing over. Sometimes a lot of people will complain of pain when their legs are crossed over, and we want to have them wide, almost like, but like sitting like a man. You want to like wide splay your legs a little bit, and that will help kind of relax the muscles and relax everything. And then the other thing you can do, if you guys want to write this down, it's called Rost Moves Mamas. I can again send that to Mommy Monitor, but what it is it shows you positions and postures that help create that pelvic symmetry that will help with hip pain or low back pain or SI joint pain in various positions. So if you're sleeping or if you're sitting and you find it's painful, or if it's transitional movements, it's an app you can download on your phone. And she is I think she's Belgium or German, and she just has that resource. And, it's not for everyone because sometimes you do have to get assessed, but that would be helpful. The other thing you can try to do is to stretch out your hip before going to bed. I hope I answered all of that. How would you teach abdominis transverse activation in the initial stage? Use of metaphors or similes, or okay, I like that. So what I would typically do for that is, I've got lots of ways. My favorite is I show people, I've asked them to find their two prominent bones on their hips there, and I ask them to slide a little bit in between, like in a little bit towards your belly button there. And then what I'm going to ask them is imagine that their belly button has now moved down to where their pubic bone is. Okay, lots of visualization here. And then what you're going to do is you're going to think about drawing in the two bones, like you're trying to pull them in together and then pull them in towards your spine. So you're going to do that on your exhale. So you're going to breathe in, and then you're going to breathe out through your mouth like this. And then as you breathe out, you're going to try to draw that in. If you keep your fingers here, what you'll feel is two sets of muscles sort of contract or bulge under your hand. And that's how you know you have it right. Well, if you see this, or you see like creasing or contracting happening up here, and that's a really great way to know that you might not be using the right muscle. And then the other thing I do is I pair that with a pelvic floor contraction. So I'll say, okay, now imagine you have a ping pong ball at the opening of your vagina. For men, I say, imagine you've got like a marble at the tip of the penis. And think about on the exhale, draw that into your body. So you're going to pull that in. So you're going to squeeze and lift it in. And then as you're lifting it in, think about cinching your waist together or trying to draw your two bones together. And you're going to feel a little tightening happening here. And that's a great way you can use that. I sometimes use a drawstring metaphor, like imagine two drawstrings being pulled together. And then what else? Got so many. I just try to work with the person in front of me so that, you know, it works for them. But I hope that helped a little bit. How do you know that you are doing Kegel exercises properly? So often the general population doesn't know that, but what you can do if you feel comfortable is you can stick your finger into your vagina if you feel comfortable. I'll show you how to do it externally too. And then you can see when you do a Kegel, do it the way you think it is. You will feel a squeeze around your finger like that and a lift. It's going to feel like you're drawing it up towards your head. And that's how you know you have a good contraction. If you've got two fingers in, you shouldn't be able to splay your fingers apart. They should be nice and strong. Now, why that's sort of controversial is because if you can't relax, you don't really truly know where you are in space. So you might think you're doing a good contraction and you might not be. I hope that helps. The other thing you can do is if you put your finger on your perineum. So the perineum is that space between the rectum and the vagina. You put your finger right there and then you take a breath in. If everyone wants to try it, you can take a breath in and your finger might start to move away. And then as you exhale, and again, you got to do the belly breath because you won't feel it with the chest breath. If you exhale, you will feel that finger draw in. And then if you add a Kegel with that exhale, you'll feel it really draw in. And that can be also a way to know the up and down movement, but not necessarily, you know, if you're very, very strong versus weak. Also with the Kegel exercise, remember, you have to be able to hold it a certain period of time. You have to be able to do a quick contraction. So can you contract, relax, contract, relax, contract, relax. So there's multiple components to it, but if you just want to see generally, are you strong? That's a great way to do that. What would be the fit principles for Kegel exercises? How much should I do in a week? So like I had said, the fit principles depends on the person, because if you're strong and it's endurance, then you're going to be doing 15 reps for 10-second holds twice, 2 sets twice a day, sort of thing. But if you are, so some people will actually use the fatigue principle. So do it till you fatigue, or do 10 really good ones, because some people just, it's that connection. It's really hard to know if you're doing it right. If you're doing a quick contraction, some people might say like do 10 quick contractions, give it a 4-second rest period in between each contract, relax, and then do that 3 times in your day. So again, it's really dependent on the person in front of you and what their symptoms are, and even if it's appropriate, because if they don't need to do Kegels and we're making them do Kegels, we might make their pelvic pain worse, we might make their that lateral hip pain worse or their back pain worse. So we have to really be careful about just prescribing Kegels as if it's one size fits all. In modified Pilates, you are thought to breathe into the sides and backs of your ribs. I totally agree. I think that if you can get that full 360 breath, you're in a way better place, because we're not two-dimensional. So sometimes I will teach people to put their hands on their ribs and make their ribs expand, or think about their back expanding. And sometimes people can do that belly breath great, but they can't get that like rib breathing that you're talking about. And that is just the key to getting them to contract a little bit better. So I think that is really warranted. And that's another thing, just to tie into the fit principles. If you can teach people, if you're in Pilates or in yoga or any sort of exercise professional, if you can teach people to pair that breathing and get that breathing down correctly, their body's going to just do naturally what it's supposed to do. So I think that's actually a bigger piece and more important than the Kegel itself. Should I stop doing Kegels until I find out, confirm whether my muscles are tight and weak? How about I say you don't stop doing Kegels, but you just incorporate that breathing strategy with it. So just doing the breathing, inhale. So how I teach people is that they inhale and they try to relax that muscle, and then they exhale and they try to tighten the muscles. So they think about drawing that ping pong ball in. Truly, when we're doing a Kegel, we're thinking about what's called the anterior triangle, so this space, and the posterior triangle. So you're thinking about drawing a a ping pong ball or a like raisin or pearl in through the urethra, and then the posterior triangle, you're thinking about drawing a marble through the rectum. A lot of times people are stronger through that posterior versus that anterior. So if you can just focus on letting go of that marble and then drawing it back up, that might be more helpful. But I would still say try to get that checked out. But we're in COVID right now, so that's really hard. I mean, we just started opening up our sessions, in-person sessions for Monday. So the people I have been seeing via telehealth medicine, I actually don't stop them doing Kegels. I just train their breathing. So I know that after they contract, they are relaxing, or they're trying to, as opposed to just contracting. I hope that helped. I would like info on perineal stretching if there's time. Absolutely. If there's time. There is time. Okay, I think. So what perineal stretching is thought to do is that the perineum is that space that opens that helps, the perineum is between the vagina and the rectum. So what is thought is that if we can help lengthen and stretch that perineum, that vaginal opening will be a lot easier. Hence, getting the head of the baby out will be a lot better for the person. So they can stretch that perineum, so the vagina will open, and then the baby's head will get easier and potentially prevent any sort of tearing or need for episiotomy or need for anything like forceps or vacuums, which are shown to have really negative impact on the pelvic floor and as well as the baby. So what we do, and I actually recommend doing this around like 28 weeks if you can, but if you can't, come in whenever. And what you want to do is you want to start on the external first, and you want to find where that perineum spot is. So you're going to just find that area between the vagina and the rectum. And then you're going to slide your finger out until you feel your sit bones, so pretty much your butt bones. And then same thing the other way. And so what you want to do is you want to hold that down, and you just kind of want to massage it out. You don't want to use a lot of force. I like to imagine I'm just kind of gently pushing into a rare steak and then just kind of pulling outwards. And I like to use the steak example because I do train husbands to do this to their wives, or any partner, to do this for the person that's giving birth, because then they don't need to see me. And if funds are an issue, then, they've got that coverage at home. So what I do is, if you go like this and you touch this muscle, and you go like this and you touch this muscle, and then you go like this and you touch the muscle, and then like this and you touch that muscle, we will feel the tightness of that muscle. As you can see, it's how you actually check what kind of steak you want to eat. But so if you feel that versus that, you can feel the difference in tension. And we want our muscles to feel like this. They want to be relaxed. They don't want to feel like this. So when you feel your perineum, that's a really great way to check if you're tight or not. And so that's the first thing you do, is that lateral stretch. The second thing you do is you pair your breathing. So again, I teach that breathing first. I get you to breathe into your pelvic floor and relax so that I can use that to help guide me in, because oftentimes people are really sensitive during pregnancy to the stretch, and people hate it because it's so painful, or that's what they say. And then we do it and it's like, oh, it's not that bad, because we have to really get those muscles and the person to relax and be comfortable with it, because it's so invasive. And then what you're going to do is you're going to move so if you see here, I'm going to move all around this region. I'm going to start here, and I don't go further than my first line here of my knuckle. And then I'm going to ask the person to breathe in, and I'm going to push gently down and then come back up. Same, and I'm going to do that 10 times. Then I'm going to move over. So that's 6 o'clock. Imagine this is a clock. Then I'm going to move over to 5 o'clock, and then same idea, go towards a diagonal towards that sit bone. Towards that sit bone. And then same thing here, diagonal towards the left sit bone. Pairing that breathing, making sure you're doing it on the inhale, and making sure that if there's pain, you're not bypassing that. We're not trying to produce any pain at all. And then we can even go 3 o'clock and 9 o'clock. So we can go this way and that way, again, very gently, just trying to open. And then the other thing you can do is, starting at 3 o'clock, you can go down to 9 and do like a little U stretch. And same thing, U stretch. And that pressure, what I typically do is I add the pressure first, and then I just make sure I'm watching the person in front of me, making sure and asking them, is this painful? What does it feel like? And then as I hold that, I slide down a little bit, and that helps just like lengthen it. And then the more you do it, the easier it becomes. Make sure you're using like oil or some type of lube, or else it becomes really uncomfortable and you might feel some friction. I hope that was helpful for perineal stretching. I recommend, honestly, a lot of physios out there you can come in, do the assessment. We'll teach you how to do the perineal stretching. You can bring your partner in. I'll have them sit with me, and I'll show them, and then I'll get them to try it, and I'll just monitor and make sure, you feel comfortable and they feel comfortable, and then I'll send you off and you'll do it. And if you have any questions, you can come back. So that's really how it is. We don't necessarily need to do an internal exam. So I've been finding that if I just hear your story and I hear your symptoms and I measure your outcome measure, I look at the measures, I can get a sense of if, you're more tight or weak. And I try to coach you through that during the live webinars. I've had a client, actually, she was about to give birth and she just wanted to go through it with her husband. So she went on a video with me, and she had the covers over, she had me up like this, and then we would just move back and forth, and I would tell him how to do it, and they would just work through it together. And it got a little personal, but I think in the end it worked out for her. So yeah. All right. And that's it for me. And yes, you're very welcome. I'm glad I could be of service.